Welcome, guys. We're super excited that you're here today. So my name is Rayanne. I'm one of the supportive housing program managers. So just a friendly reminder that there's 4 of us, and my focus is primarily on the east side, and so most of the rural counties. If you belong in one of those counties or your agency is there, I'm your person. My role is to support you and your with anything and everything that has to do with supportive housing. That includes training and working with the agencies to update you about funding and different opportunities, and then of course system kind of guidance and what that might look like. So today we're super excited for this webinar, and I really hope that you guys walk away, each of you, with something new and you learn something and it really gets your brain moving. So today we have someone who's really passionate about homelessness and research and kind of how those two fit together. So today, really the goal is to hopefully help you connect the dots between the folks that we serve and the research that we read. When we talk about fidelity, so a lot of you are familiar with fidelity and the permanent supportive housing evidence-based practice, we spend a really significant amount of time talking about participant feedback. Why is it important? How do you collect it? What do you do with that? So this highlighted project, they're going to walk through it. They've integrated some new services and they really wanted to find out, is this actually helpful, right? What do the participants think about all of these services? So today you'll meet Dr. Hilton. He'll walk you through how a PSH project worked with researchers to collect some qualitative data, so that, all those words, and how to theme that and make that into some data points. Like, what does that mean when we're just talking to our folks? If you have questions throughout the process, please ask throughout. Dr. Hilton is really fluid in that. If you feel more comfortable, you're welcome to message them to me and then I'll ask. Otherwise, we'll have some time for questions at the end as well. So this is a super great opportunity. I hope that you just go in with an open mind, kind of get your minds flowing and exploring about how the system really impacts the folks that we serve and really influences their experiences and how that might impact your work with them. So with all of that, welcome, Dr. Hilton, and the floor is yours.
Excellent. Well, thank you, Rayanne. I appreciate that. For those of you who don't know, Rayanne is one of my former students, and one of the ways I know that I'm not doing a terrible job because she does such great work. So thank you for everything you do, Rayanne. Just want to open up my presentation. So I was approached, gosh, it's almost been a year and a half or more by a few folks at VOA who were interested in some kind of evaluation of their permanent supportive housing program. At the time, VOA was in the process of hiring some new folks, a nurse and some behavioral health counselors to come into their permanent supportive housing program to work with some of the housing case managers who were already working on the program. And so really, they were interested in how this new interdisciplinary team worked, and whether or not it was valuable and a good model. So just a little bit about that model. And I know things have changed since then, and things are always changing at a lot of agencies. But at the time we looked at this, it was an interdisciplinary method of service delivery. What was referred to then as an enhanced care team with a case managers, integrated healthcare, so there was a registered nurse on staff, and behavioral health care. Some licensed mental health clinicians who were on this team who were serving residents of the permanent supportive housing program. The agency also had what was called a tiered approach to services. So the residents of permanent supportive housing were divided into 3 groups based on their level of need, so that they could target the most intensive services for those with the greatest need. Permanent supportive housing primary goals are low barrier entry, as many of you know, housing retention, positive exit, so those who are leaving housing into permanent housing outside of the program, and increased wages. And this team's goals really focused on improving access to healthcare, mental health, substance abuse treatment, and other services. So a big goal here focused on healthcare and what connections or positive connections can be made to healthcare services outside of the agency. Also focused on improving overall quality of life for the residents and to help residents develop their own ability to navigate services in the community. For example, to have decreased use of emergency rooms for routine healthcare needs. Again, connected to that healthcare goal of trying to make appropriate connections to primary care physicians. Okay. Oops, sorry. So our research really focused again on the impact of the enhanced care team. And our primary question was, how does this model, this interdisciplinary enhanced care team model, work to engage PSH clients or residents in healthcare, mental health care, substance abuse treatment, and other services? So we took what was called a qualitative approach. Our goal wasn't to evaluate specific numbers of people who, saw physicians, or to look at cost savings, or to look at specific outcomes. But we were really interested in understanding sort of the experiences of both the staff and the residents, and how they experienced this program, and what this enhanced care team meant to them. We did in-depth semi-structured interviews. We had an interview guide, but we also allowed residents and staff to talk about other things that were outside of our guide. We used what was called convenience and purpose of selling, meaning essentially we relied on the people who were willing to talk to us, and we did a lot of outreach to try to get a good diverse group of folks. We ended up speaking with 27 permanent supportive housing residents, and I think we now spoke with 14 program staff at 2 downtown housing locations in Spokane, the Merrily and Hope House, and that's the new Hope House location. Our analysis included thematic analysis, looking at themes that emerged in interview recordings and our field notes, and we were looking for common themes and experiences in the perspectives of residents and service providers. Just a few general findings. The first one, kind of a big one, is that all residents showed substantial medical and other related trauma. So the folks we talked to felt that they'd been mistreated by medical and other service systems in the past. Many of them had a lack of knowledge and an ability to navigate systems, and many avoided services even when they had extreme needs, right? So there was a lot of what many people call medical trauma that led to an avoidance of services, which I think is consistent with what many folks have seen in PSH clients. What we did see also many examples where the enhanced team models, their collaborative process worked as a bridge to healthcare and other services. So we did see a lot of success in bridging people to appropriate medical and other services. And we also saw that there was some key relationship building strategies that were used to increase clients' willingness to engage in healthcare and behavioral healthcare services. And I'm going to talk a little bit about some of those. First, I want to speak about this avoidance of services just a little bit more. We heard a lot of talk about medical and mental health service related trauma. Many of these residents had been engaged in involuntary holds and the loss of rights and autonomy. In some cases, this was probably appropriate. However, this can be a very traumatic experience, especially for folks with severe mental illness, oftentimes who were not receiving treatment for that. Some felt that they had been dehumanized by some providers. Many felt or experienced that when they did seek help, they were often accused of seeking drugs. Right? So that made it very difficult for them to receive care when they really wanted it. There was often a lack of knowledge and an ability to navigate systems. So many had limited knowledge of their bodies and health in general. Nutrition was something that folks did not often know a lot about. We saw a lot of inappropriate use of ER and emergency medical transport for things that are relatively routine medical conditions. Substance abuse and untreated mental illness was prevalent. A lot of behavioral health providers unwilling to provide treatment to people who were using substances, which can contribute to the avoidance of services. Many people reported that there were judgmental attitudes by service providers about substance use and addiction. Some also experienced some paranoia and fear of leaving their apartments. Just in general, talking about some of these successes in basic terms, we did see housing retention. Obviously we were speaking to people who were still at these places, but there were many stories we heard where housing had been saved because of the efforts of staff and their relationships with staff. Lots of connections to health and behavioral health care services that had been made. A lot of residents that we spoke with who were able to get healthcare insurance, establish primary care relationships with primary care physicians. Many people who were connected to specialized healthcare to address untreated health issues. We saw examples where people with chronic disease, after long period of time of having no treatment, had regular disease management. We saw several examples where people were now receiving psychiatric treatment and medication management. We heard many people talk about their reduction in ER use and other emergency services for routine medical services. And we do hope at some point to do some research to look at some of the quantitative data for that. We also saw many people who described their abilities, the increased abilities to advocate for themselves and to develop some problem-solving skills. So, people who became more savvy at navigating community services in general. One of the things that we saw as being very important to connecting folks to services was the importance of relationships. As we said before, there was a lot of avoidance of services by many clients, and many who had fear and past trauma that led to the avoidance of healthcare and other kinds of services. And when we began to ask clients or residents about, how they began to overcome this, a lot of it had to do with their relationships with the case managers, some of the behavioral health folks, and the staff nurse. And as we talked with staff as well, what we saw was that it's very important that the residents are familiar with staff. One of the nice things about the interdisciplinary nature of the team was that the nurse, the behavioral health specialists, and the case managers are all on location, and they're seen together, and they're seen often. They become familiar, they become known as people who work for the agency that they trust. And that was really important to beginning to develop some of these relationships that became important in bridging to services. We saw many examples of engagement and the importance of engagement and the importance of things like a warm introduction. So many of the residents, for example, had long-term relationships with some of the housing case managers who worked at the agency. And the ability of those folks to introduce them to the nurse was really important in allowing the nurse to have access to be able to engage these folks. We saw several methods of engagement, sometimes providing free stuff. So sometimes it's important to provide some basic necessities, food and shaving products, shampoos, and other things like that to begin to develop a positive relationship before some of that case management and bridging services can happen. So it was really important that many of the services were offered in-house. Some of the basic healthcare services, the behavioral health services, which happened within clients' apartments. That was really important to many of the clients. And many of the clients said that's how they ultimately developed some of their first relationships to behavioral health and healthcare professionals in a long time. We saw it was really important that the caseworkers, the nurse, and the behavioral health folks developed what we call the progressive involvement in some of the external services. And we'll see this in some of the quotes in the future, in the next few slides. You know, examples like somebody who would very scared to go to a hospital, you know, at the very beginning, developing a relationship with a nurse who might ask about a wound care or some kind of chronic pain, ultimately providing some basic service in somebody's room, to working with the nurse to develop, to make a phone call, to make an appointment, right? To the nurse attending the appointment with a client. To the nurse being the bridge between the client and the interpreter between the client and doctor, and an advocate for the client within the facility. So it's this progressive involvement, right? Warming up to the use of external services. And, you know, kind of a basic idea that we saw, a theme that came again and again, was the importance of persistent patience and unconditional acceptance. This idea that clients are afraid of disappointing folks. Clients have experienced failure in services in the past. And sometimes they drop the ball and don't attend a service, or they don't go to a meeting, or something happens. And what we saw is just the continued importance of trying again, and being consistent and being available, and continuing to accept and to continue to try with folks who might miss several appointments, for example. The team model. Again, as I said before, warm introductions and familiar faces was really important. It wasn't just that there's a new nurse on staff, but there's a nurse on staff who's been around, who I've seen with my case manager. It may take a month or two seeing this face before I'm willing to let this person in my apartment. And we saw that was a real thing, and we saw that from the perspective of clients. One of the things that many of the staff reported was that having folks who can focus on Medical services and other folks who can focus on behavioral health services allowed the case managers to focus on housing as a priority, right? So we did have some specializations that developed, right? This increased the ability to bridge residents to both internal services and to community resources. So, for example, having a nurse who is intimately familiar with healthcare systems allowed her to be especially successful in navigating the unique needs of the residents. And that was really important. We also saw that there was a lot of collaboration, information sharing, and shared knowledge of client needs. So, various staff folks who interact with clients in different ways can share some of that information with one another, which can be really important for service planning. One of the other things that I think was really important and somewhat surprising to us was how there was a shared commitment to the program model, right? As many of you know, permanent supportive housing focused on a housing first and harm reduction model is still relatively unique and relatively new in the world of social services. And just to have this shared understanding of the model and a shared commitment to housing retention as the primary goal, and the harm reduction philosophy, and just the shared commitment to harm reduction and not requiring commitment to services or participation in services in return for help, I think was something that was prominent and I think important as well. Okay. So just a little bit about the healthcare integration, and I've mentioned some of this before. There was a nurse on staff at the agency, was familiar to the residents and often introduced through the case managers, which was really important, right? A lot of the engagement focused on the residents' immediate needs, things like wound care and pain management, sometimes around issues of mobility, right? Oftentimes this led to gradual introductions to community-based services, right? We'll see in a quote in a second, people who had this intense fear of even making an appointment was a little bit easier when it's done with a nurse in your room. She attended doctor visits with the residents, interpreted and advocated for the client when attending medical care appointments, helped the client secure and manage medications and prescriptions, which was really important to a lot of our clients who had chronic mental health conditions. And then also teaching the clients to navigate healthcare systems in the community. Okay. Just looking at, as we said, we did in-depth interviews with several of the residents. One of the quotes that stood out to us, the client said, "I feel healthier since I've been here. I look healthy, but my body was pretty worn out when I was out there meaning on the streets. I'm going through some good changes here. Coming to PSH was probably perfect for me. I know it was." Again, it's the importance of housing and housing stability on somebody's overall health and outlook. Sort of looking at this integrative team model, and particularly the impacts of nursing. Client says, "The nurse was amazing. She knew I hated hospitals and doctors, but she looked at my ailment, right, for me in my apartment. She wanted me to see a doctor, but I didn't want to. She came back and talked to me a few times. Eventually I said, okay, I can go, but I don't have a phone to make an appointment. So we used hers. She called with me and we made an appointment. Then she took me to the appointment and stayed there with me. She talked to the doctor a few times to make sure I was getting the right help. That made it much easier for me, right?" So, just a real clear example of how intense the level of commitment has to be to connecting somebody with a medical provider. And you can see, there's so many times where, an effort to connect somebody could go wrong, right? If having a phone, I don't want to make the appointments. How am I going to get there? I'm scared to be there. Somebody's going to be with me, right? All of these things and the level of intensity that's needed. And that's, I think, kind of a basic but a clear example of how this model can be successful. We talked to several of the behavioral health counselors, and we talked with clients about their use of behavioral health services internal to the agency. The focus, at the time at least, was primarily on behaviors related to housing retention. So things like hoarding and cleanliness, organization, things that could be related to somebody losing housing. We saw many of the clients talk about fears, anxieties, and depression and loneliness. These were also commonly addressed by the behavioral health counselors. Referrals were made by the case managers in most cases. Clients were seen in their homes and apartments, which we heard from clients was really important. There was some collaborative goal setting using a trauma-informed and mindfulness frameworks. So again, a lot of this was client-centered, focusing on what the client is interested in, and a lot of gradual involvement in services. It seemed that there was greater flexibility than with a lot of other behavioral health treatment providers. A lot of accommodations that allowed many people who were reluctant or would be reluctant to use behavioral health services to be able to do so. And the idea, or at least the model, was short-term therapy followed by referrals to external mental health treatment options. Again, the model being get people used to behavioral health services in a familiar, comfortable setting in their apartments, and then gradually introduce people to external services. So just from the client perspective, a few of the quotes. It's easier for me to talk about personal things here in my own place. Again, it's the importance of having these services offered conveniently and in a comfortable place. I don't really like to talk to a lot of people because I fear rejection, but it has helped, I think. At least I feel better after she comes to speak with me. Right? Another person saying, I might get emotional during therapy, and it can be hard to avoid using meth if I'm outside and feeling like that. If I don't have to leave the apartment, it is easier to not use. So again, a lot of this points to the importance of having services in-house. And then, finally, talking about case management. Many of the clients told us that their case managers are the most important person in their life. And we heard this many, many times. Clients are assigned case managers when they enter the PSH program. The case manager's primary focus is housing retention, but this really covers a wide range of issues, anything from food to cleaning supplies to transportation, shopping, banking, and financial health, and lots of different things that are centered around housing. We saw a lot of the case management being instructive, teaching people to navigate the community at large, how to do some basic self-care, how to understand and how to engage in appropriate social life. Some of it was built around community building. How do we build community within permanent supportive housing? Clients talked about the importance of food banks, the ability to get food, some of the social dinners and games and activities that took place in these housing developments were really important community activities for the clients we spoke with. But we did see a lot of variability in terms of the level of engagement and the level of interaction between clients. But by and large, the most common thing we heard was the importance of the case managers. In one client's words, they know how to get you stuff you need. Like they know how to go up the ladder in the right way, to start at the bottom and work your way up if you have to to do it to get what you need. Like me, I would just start at the bottom, and they don't like that. Plus, sometimes I have a psychosis, and that doesn't help. They help me with SSI and food and clothing and other things. They are just really supportive of me. Right? So you can see, obviously, the importance of case management to this person's life. Another client stated, my mind has become disordered. I don't think as well as other people. But being here, being around other people, that has helped me. I feel like I have a little more control of my life. Like the case manager and a few other people, they talk to me. They help me. Little baby steps here and little baby steps here. I feel like I can get my life in order. So, for many folks, the case manager was an important person in their social life, right? And important in helping the person feel comfortable just talking to other folks. Final thing I want to talk about is related to this team, and it has to do with staff and the actual team itself. One of the things we heard from both some of the managers and the staff was the importance of selection and recruitment. Finding folks who are going to both understand and be committed to a harm reduction sort of housing first model. And it seemed to be really important to find the right people for this type of program, and that seemed to be really important. A lot of orientation of harm reduction, housing first and PSH, and many of the folks we spoke with talked about sort of the challenge of getting oriented to that and the importance of having other staff really explain it to say, what does it mean? What does it mean to have a harm reduction approach? And I'll talk a little bit about that with some quotes from some of the staff. Staffing and supervision were very important, especially to
Lily, you get to pick the first show. You can pick one on YouTube, that's fine.
Okay, so staffing and supervision were really important, especially to help reorient people to harm reduction and permanent supportive housing models. And I'll show that in just a second. Burnout, self-care. Many of the staff talked about the stress of the work that they did. Clients with extreme needs. Sometimes clients get very ill. Sometimes clients die. We've seen clients who, may have had improvement, have had relapse, and sometimes don't make it. And it can be very, very stressful for a lot of staff. Having a team of people who understand this, having supervisors who have reasonable expectations, and a shared understanding of the job and goals. And again, the shared understanding of permanence, of harm reduction and housing first models seem to be very important to the staff. We saw many examples where staff talked about the importance of assisting one another in support and having other people who can cover in some cases being really important. The importance of celebrating small successes. Staff talked about helping a client get a license or a state ID after many years of trying to get a client's paperwork together, being cause for celebration and being celebrated with the clients, being celebrated with the staff is something being very important. Just an example of the importance of supervision. This is from one of the case managers. He says, I was working with a client who was being evicted and I was having a hard time with it. I spoke with my supervisor and she said, you know that when your client does something good, it is not you. Well, the same is true when the client is doing something that isn't good. It is not on you. You are there to be a resource, but they make choices and they have their own life, right? So I asked the staff person, the case manager, I said, how do you know if you're doing a good job? And he responded, if I'm trying my best. And so this really, I think points to the importance, right? And the supervision seems to be very unique because in a lot of social service settings, you measure your success based on the number of positive outcomes you have. Well, obviously there are some positive outcomes out there in terms of housing retention, and a few folks who might leave permanent supportive housing for housing in the community or to get a job and those types of things. But very often, what you're seeing is, small gradual incremental steps towards getting people connected with services, improved quality of life. But in some cases, success is just, keeping somebody housed for the remainder of their life. And I think for many staff, that can be something that can be stressful, and having somebody, other folks, supervisors, other coworkers, reinforce the importance of just being there. It seems to be really important to a lot of the staff. Defining success is a challenge, especially when working with extremely vulnerable clients and residents who had been on the streets for many years. Many remain reluctant to use services, many use substances, and many have untreated mental illness, right? Maintaining housing is the shared primary goal. Connecting clients to services is a secondary goal and can support the goal of maintaining houses, right? Sorry, maintaining housing. What we saw is that staff see themselves as resources. They make themselves visible and available to clients. They build trust with clients and residents over time. So success is somewhat ambiguous, hard to measure at times, and can take a long time to see, right? What we saw is that staff and administrators seem to understand that success is defined and achieved by clients, right, and not the staff themselves. And this seems to be really important to the staff morale. In the words of one of the case managers we spoke with, who said, "If someone died or lost their housing, I thought I failed. I thought it was my job to keep them housed and alive because that is usually the definition of success. When I started to reframe what success meant, my mental health improved. Then none of the days are a failure. It's about the process and the services we're willing to offer to people, and if we're treating them with dignity and love and respect, even when they're cursing at us. That is a success for me. Someone can yell at me and I can come back the next day and say, I'm still here. I'm still going to be here." And I thought that was a really important quote, and I think it really points to the importance of this shared commitment to the PSH approach in the philosophy of harm reduction. So just to summarize some general findings, the PSH and enhanced team model created positive changes in overall quality of life for almost all the residents we spoke with. We saw that service avoidance is strong and common, but some of this relationship building with residents provided many examples that were critical in overcoming avoidance and fear of services. We saw the enhanced team model allowed for some specialization. Some of these warm introductions, which were really important in engagement. Coordination of services and this shared commitment to treatment philosophy, right? We also saw it was really important to have an inclusive definition of treatment, right? So treatment could be just coaching somebody in how to make an appointment, for example. Some of the implications, I mean, I think there needs to be more support for PSH, housing first and harm reduction, because I think for some of our clients with the greatest needs, this may be the only way to find long-term safe housing. Greater street outreach that addresses the challenges of engaging people who are chronically homeless. I think one of the things that our research says to me is that it's really, really hard to engage people who have avoided services for a long time. Knowing this and having sort of more targeted, ongoing and consistent outreach may be really important to engaging people who are chronically homeless and avoidant of services. I think it's important to educate service providers on medical and mental health related trauma, to understand the level of avoidance and the types of avoidance. Obviously, we need increased availability of and access to mental health, addiction, and other services. One of the things we saw, for example, with relationship to addiction services is that very often when somebody was ready to make some steps to begin addiction treatment, oftentimes there was not treatment available at that given time. So windows of opportunity can be lost when those things are not available. And then the potential benefits of the enhanced team model and the importance of provider specialization. So it's the ability to specialize, but also the ability of interdisciplinary support that seem to be really critical to this model. So just really quickly in the coming years, my research partner, who's not here today, Kara Lopez, and I are interested in looking at differences between scattered site housing versus the centralized housing. We focused here on centralized housing, housing at 2 of the larger PSH units. So we wanted to see if there are differences between the two models. We're also interested in this tiered model. The idea of separating clients into groups based on their level of service need. We focused a lot on the highest service need, so we're interested in the impact of services for other tiers, right? Other tiers where people have stable housing, where people are generally engaged in community services, and we wanted to see the impact of services aimed at employment, general mental health, education, nutrition and health, and securing permanent housing outside of the program. And we're also interested in what factors might be related to the step down between tiers in progressive success. How do we move somebody from one level to the next? So those are things that we're interested in studying in the future. So anyway, that's my presentation, and I'm happy to take some questions and hear from everyone. So thank you for listening.
Thank you, Tim. Does anybody have any questions about the process or what that looked like? I was curious, Tim, if you could speak to kind of what does that look like in research with trying to eliminate any biases or make sure that, you know, participants didn't feel pressured by staff? Like, what was that process for you guys?
Yeah, we thought a lot about that. You know, whether or not, you know, for example, we were really trying to make sure that clients didn't feel pressure to talk to us, A, and B, that they didn't feel that they had to say positive things about the agency just so they could keep their housing and other things. So one of the things we found is that we certainly didn't have to worry about people wanting to talk to us. There were people who wanted to talk to us, and some who came because they wanted to complain about some very specific thing. Others who came because they wanted to let us know, you know, how important staff folks were. I think one of the things that we really tried to emphasize was the importance of the voluntary nature of speaking with us, and being in a location where they could find us, but not sort of if they wanted to come speak with us, but not hunting folks down. Doing it without their case managers, I think, was sometimes important, so it didn't look like people were being pressured. Now, in terms of our own biases, I mean, one of the things that we did, Kara Lopez and I, my co-researcher, we evaluated these interviews separately at first, and then came together to see if there were discrepancies in the ways that we looked at some of these services. And I think another thing is, you know, when you look at our reports, for example, they're full of quotes. So the less that we speak, the less that we're giving interpretations, and more that we're grounding what we say in the data, in the words of clients. I think that helps to avoid our biases, right? If we can present the data in clients' own words, and try to make sure that we give a range of positive and negative responses. So yeah, that's some of what we do. I have a question here from Aaron. Can you expand on the collaborative focus of the staff and residents on expanding their social lives? Some staff at PSH sites aren't allowed to work on this aspect. Seems very important, though. Yeah, we did hear a lot of that. And a challenge that we faced, we did most of our interviews towards the tail end of the pandemic, right? I mean, I want to say the tail end because I know it's we're still in an endemic times and it's still around, but we had seen some frustration on the part of some of the clients around social life in a few ways. One is there seemed to be a limitation of the number of guests who were allowed in apartments. I don't know if that was entirely around COVID or that was just more enforcement of existing policy. But that seemed to be a frustration for many folks. Another piece that was a frustration was there seemed to be, at one point, I think in these developments, there were more opportunities for community dinners and other sort of public events that seemed to be important social outlets for a lot of the clients, and some expressed frustration around that. I will say this, that the social, we did ask about social life and relationships like between the residents and apartments, and that really ran the gamut from, you know, some floors where we saw, you know, 5 or 6 people who were very close and considered their neighbors the closest people in their lives, and they would get together for coffee every morning and seemed really important, to people who really were scared of, you know, the people who live next door and other things. So it seemed that there was some focus on social life and instruction from their case managers and how to navigate some of those kinds of things. But in some cases, it was, you know, more of policing, right? I mean, not, and I don't mean policing like police state, but more of like, you know, how do we resolve tensions between neighbors, right? But that is a good point. It does seem that a lot of the people we spoke with said they would like to see more focus on social life.
Thank you.
Yeah, thanks, Erin. Michael, did you have a question?
Well, yeah, because I actually, you just kind of touched on what around my question, because
Yeah.
I've been doing this type of work for the past 6 years now, and working in supportive housing in a permanent facility. I also now I'm currently working on the grounds where I have residents that are on the property. They're young adults between age 18 to 25, and you know, the social engagement is kind of what there is an issue with, I think, because you know, they are limited to the amount of guests they can have, the amount of company they can have over. They are, you know, and then also the other structures of like the units that they're in don't have stoves and things like that. So it's constant sort of always, how do we get the social aspect into where they're starting to be more social and breaking away from the things that they've been, you know, dealing with, anxieties, mental health, abuse, you know, substance abuse, all those things, and how to get them social in a way to where they're interacting socially with people that are positive in their lives instead of negative in their lives. But it's also that I'm a watchdog, like you're breaking this rule and you can't do this, or, you know, so it kind of puts me in a dual role where it seems like, yeah, I'm here to be supportive, but I'm also playing a parent in a manner, as a person who has grown children and you know, young grandchildren. It's kind of like that fine line. How do I maintain the rapport of being someone that they can come to and discuss these things with, when I'm also playing the hat of you're breaking rules and you can't do this. So,
Yeah.
you know, it really puts that strain on the relationship. I mean, I've even experienced this when I was working with, you know, adults in housing, where it kind of like, I'm an authoritarian, but I'm supposed to be supporting you at the same time. And so that's kind of where that line falls in. And how do we fix that? Because in some organizations, that's just kind of the norm, the way you're supposed to do it. And I think that the way we're trending, you know, even especially after pandemic, and we're still in that, is that the social part needs to be there.
Yeah, I mean, Michael, I couldn't agree more. Now, in terms of how to do it, I don't think I can give you a good answer based on what I've done. I can tell you that what you describe is certainly echoed in our interviews. We saw folks, for example, say, "Hey, listen, I've been on the streets and I've had this network of people on the streets, and this is what's helped me survive. And now I'm indoors and I have secure housing, and they're all outside, and I just feel terrible, right? Because I have this and they don't, right?"
Right.
And that was a big deal. This housing guilt came up again and again. Some people express some anger, for example, I have housing, you say it's my apartment, but then you can't allow me to have somebody else stay with me, or they can only stay so long, or,
Right.
why am I in here, but my boyfriend is living in a car? Those types of things we saw a lot. And I don't know the answer, because obviously there's safety issues for folks in scattered sites units. There's landlord rules about who's on leases and other things. But I will say this, that I think it's needs more attention, right? I can't tell you what the answer is, but I do think it needs more attention, because the idea that we take somebody off the streets and we help build their social network, I think, is a little bit naive, because they have a social network, right?
Right.
I think too often people think of the homeless as people who are outside of society. Well, they're not really outside of society. They're a different part of society, and they're connected in multiple ways to lots of people,
Right.
including family, including boyfriends, and including, all sorts of other, people who help them survive. And what happens when they come indoors, right? I mean, I think it's naive to think that all that stops. So
Right.
I
And
do
then,
think,
yeah, and my experience is because of some of the housing buildings and things that we've been building housing,
yeah,
permanent supportive housing and things like that. But then there's, from my experience when I was with another program was, we moved these adults off the street and we put them in
yeah,
this permanent supportive housing where they have the support. But then, they have to check their guest in every time
yeah,
a guest comes in. The
right,
guest has to provide an ID. I
right,
mean, the way it's structured is almost like I'm being institutionalized, even though I have the freedom to come and
yeah,
go as I please. And then I'm, mandated to meet with my case manager. And I'm, so it's like all these different factors that we put on top of them instead of just saying, hey, you know what, here's housing that you can afford. We're here to support you, and go from there. But there's a lot of regulatory things because of we don't want people coming in and out of the building that not supposed to be here. We want to cut down on the drug intake. We don't want that.
right,
We don't want violence. We don't want all these things happening in our building, but we're taking these people off of out of the community in which
yeah,
they're used to dealing with and their friends, and putting them in a different community setting where they now have to get along with people they don't even know, right? And
yeah,
then try to rebuild all that and then put them on restrictive, like you can't come in to the building after a certain time at night. You can't, have guests over at a certain time of night. If you want to have an overnight guest, you have to check with your case manager to get that approved. To me, I mean, because I've had that where I've had people just like, you know what, yeah, I'm living here and it's nice. And yeah, I don't have to worry about being on the street, but I miss all my friends. I can't
right,
socialize. I can't interact with them. We were doing harm reduction, but I'm not allowed to do this. I'm not allowed. So there's so much more restrictions on them to where it's like, you know what? I'd rather be out on the street and be homeless than to have to deal with being restricted in a place that I'm supposed to call my home.
right. Yeah, and I agree, Michael. It seems to be that something that needs to be done in a more serious way, and I'm not talking about at this particular agency I looked at, but I think in permanent supportive housing in general, right?
Yes,
Just
yes.
how do we maintain healthy social relationships with people we knew in the past, right? Some of
Right.
whom maybe not be living healthy lives, right? Because if we don't address it, I know it's going to be a constant challenge for folks. And I'll be honest, I haven't heard a lot of people talk about social networks amongst the homeless. When I started doing homeless research, I don't know, 10, 15 years ago, I looked at sort of helping networks amongst people living on the streets. And a lot of people I spoke with said, what are you talking about? Helping networks? People on the streets, that's when you're outside of society. You're not connected to anybody. And I'm like, that's not true. I mean, people still have families that they still interact with.
Right.
Even when they're on the streets, they have each other. They have relationships with service providers, even if they're still homeless. And it's infinitely complicated, but I for better or worse, I think we're just, I think homeless services in general is just catching on to this and the challenge of that. So long story short, I don't have an answer for you, but I do think it needs more attention.
Well, it's good to come. I mean, because this conversation is good to have because it's not really been talked about,
Right.
And, we might have talked about it amongst ourselves and our own organizations of going, okay, but as far as we know, this is the norm, right? This is the structure in which we've been given on how to handle this particular population of society when, it could be me, it could be my friend next to me, it could be anybody I know that all of a sudden is homeless. And now that you're homeless, you have this stigma that's put on you that the reason you're homeless is because you're lazy, you're on drugs, you don't want this, that really has nothing to do with it. But that's the stigma that we put in our societal, in our particular norm society, us people who are housed people, I'm sorry, but I've worked with people throughout all different ranges. And, even if you're in your own home where you're not in a permanent supportive situation, you're still needing that foundational community supportive housing, supports. You still need that some type of support. And, and for to have someone go, oh, we're going to house you, but now we're going to control everything you do. And tell you how you're supposed to do it and tell you that you're supposed to meet with this person. And if you don't meet with this person, then you're going to lose your housing. So it's kind of like that you're taking me off the streets, but then I'm threatened with housing. If I don't do what you want me to do, then I'm going to be back on the streets again. And some people have already made it up in their mind, you know what, I'd rather be on the streets doing what I normally do instead of having someone regulating what I do. And if this is supposed to be housing for me, because when I'm on the streets and I'm living wherever I'm living, I still do what I want to do. I go where I want to go. No one tells me what to do. And so I'm just thinking of how can we restructure the whole permanent supportive housing to where we're actually providing this social society aspect of it, where we are allowed to be social. I mean, I used to try to do functions in the building, like I'll have a barbecue or I'll do something just to get people interacting with each other because it becomes so isolating over time. And if you're dealing with mental health issues, you're isolating yourself, that increases the chance of not being housed. Then so it's kind of like that whole, when we it's like touching on people's societal and emotional connections is just as important as telling someone, hey, you're housed now, so you need to stop doing this stuff.
Right.
Well, that's not going to work.
And I do think, though, I think this instructive case management, including social life in this, is important. It's like, you're in an apartment and, that doesn't mean you can't see people outside. It doesn't mean that they can't come over. It may not even mean that they can't sleep over, but it does mean you can't have them live with you for months, right? Or you can't have 30 people staying in your apartment or having this party. Because I mean, even if you're out, in a private landlord and in an apartment on the, anywhere, that's going to be problematic too. And I think that's the kind of instruction. How do you set limits? What's appropriate? How do you be a tenant, right? How do you be a good tenant? And I know that's done, but you're right. I think it is complex. I see Dale has a hand up.
Hi, Dr.
Hey, Dale.
I'm curious to see on the subject of the, because in Spokane, we have the right away happening right now. And there was a survey done for all the 600 participants and that Camp Hope.
Yeah.
Some of those individuals will not move without their family of choice.
Yeah.
So the new shelter is being set up with pods of those families of choice. So
Yeah.
to try bringing people in, like 6 people together, to support each other. So I think we are evolving to try to understand, and if there's innovative ways with PSH to bring that to the funders, and talk about that, because that might be a different residential setting than through a scattered site process. So I think that's getting into participant feedback, asking about the quality of life that people are really trying to achieve, and understanding and digging down a little bit differently about sort of that, what is their intentions, and because I think that's where we get out of the judgment, of sort of what has been historically, they might have been thought that society puts, on them because they have been homeless.
Yeah.
One thing that, and to expand on that about social violence per se. You look at the wheel of violence, intimate partner violence, and you look at like myself, I'd be in the center, and then, if I was in a partnership, I could have financial, violence on me, or physical violence and such. I see that socially, we do these matrices around that we put pressures on each other. And there's some kind of research to look at, do you feel that maybe the access to medications, because that's like violence. If you can't get access to your medications, that's a social setup to your failure, or fiscal, and if there's something that we can look at, because society takes on behaviors in itself.
Right.
How do we really look at that, and asking the question, if they have a perception that the social network around them has been not very healing to their spirit. So those are just some ideas, and I think we are in some great space of expanding and looking forward to how we can do this. But this is great research. Thank you.
Yeah, no, thanks, Dale. That's a great point. And it is nice to hear that there's talk about the social networks and families of the folks staying at Camp Hope. For those of you from outside of Spokane, Camp Hope is a tent community along the highway where there's now about 600 residents. And there's a new large shelter opening. I intended to house some of them, and recent talk of a agency buying a motel that's going to house another group of them. But a lot of discussion, right, about whether these folks are going to go, and what are the conditions in which they're going to live, and whether some will prefer to stay in the camp. So I am glad that there is talk about that. I think one of the challenges, though, for permanent supportive housing is the rationing problem, right? Collectively, we ration permanent supportive housing towards the neediest of the needy. And, obviously, as you guys know more than I do, it's about specific scores that prioritize folks for permanent supportive housing above others. And it does make it a little challenge to think about housing groups of people together and keeping, couples together and groups of friends and such. But thank you. Ty, I see a question. Ty?
Sorry, unmuted. So what you were just saying, you brought up a really good point. People who come out of homelessness and get into permanent supportive housing, which is where I'm working right now through Pioneer Human Services. The clients that I'm working with are making between $0 and $700 a month, or $800 a month in most cases. And so they've got housing, but they have hardly any funds to take care of any other necessities in their life. And it's really hard to find resources for people who aren't homeless and do have housing, but no income, hardly any income.
Yeah, a good point, Ty. And I would say too, when we talked with residents about suggestions, finances were something that came up quite a bit. Many residents that would like, for example, help with taxes so they can get tax refunds and stimulus checks and other things, which seem to, just having a little bit of money to buy, toiletries and
Yeah.
some cigarettes or whatever it was,
Mhm.
that somebody wants, seem to be really critical. And one of those things when you're focused, I think, on housing and mental health and other stuff, financial services are something that, may not always be addressed.
Yeah, I think the population of the people in permanent supportive housing, their plight is just not recognized.
Yeah.
Just because they're kind of in between now, that they're living in abject poverty.
Right.
And real quickly, I don't mean to jump in, but I'm also even with that, with people having lower income and not being able to afford market housing, which most of us can't afford now anyway. But it's also, I've noticed that with my clients, and other clients I've worked with, is that we've moved a lot of stuff to the internet, where most of all services have been through the internet, and not trying to navigate the Social Security site, trying to navigate DSHS now, that stuff is more difficult. And especially if you're a person, one, who doesn't have the internet, two, doesn't have computer savvy, those are an additional barrier that, even though we're saying we're trying to help, is creating more of a problem. I have a situation where I have a client who has never had an ID in Oregon or in Washington before, but they don't have their birth certificate. They don't have all the other documents that are needed in order to get an ID. So that's a barrier that they have now that we have to try to get over, because that's stopping them from even getting employment or moving into other areas of society. And that comes up so much that in my years of doing this, it's been coming up a lot, And so there's all this runaround and paperwork and frustration where people are just like, you know what, I just can't do it, or I'm just going to give up. And this is where I come in too, where I'm like, okay, you know what, we're going to sit down and we're going to try to get through this.
Right.
But it creates that frustration where, after a while, someone's just going to be like, you know what, I've tried all this stuff. I keep being told I can do this and do that, and I keep running into barrier after barrier after barrier to where I just give up.
Yep.
And I might as well just be homeless or be on the streets, because no one really cares anyway, even though that they say they do. And I do run into that conversation. So I'm glad you're doing this type of research, and I'm glad I actually attended this meeting, because it's brought up a lot of thoughts that I've had, like, how do we start fixing the social part of, helping people maintain and be stable in their housing? I mean, there's all these different factors: domestic violence, drugs, finance. Right now, economy's crap. We won't talk about that.
Right. Yeah.
It's I even look at it myself, if affordable housing keeps going up the way it is, I'm not even going to be able to have a place to live without having, additional people living with me, where we're so it's kind of like, we keep saying, let's do this stuff for affordable housing, but the housing is not be affordable. And then for the people who are in stable housing, their rent keeps going up every year.
Yep.
Like, I know in the next couple of months, because my lease is going to be coming up in December, I know there's going to be another lease comes out and says, oh, you're going to increase your rent.
Yeah.
I have a friend that their apartment complex just increased their rent, but then they are now charging them $35 for parking if they have a registered car parked. So it's like, how do we even focus on the fact that housing is becoming more and more expensive, and landlords are figuring out other ways of tacking on fees and things like that, to where we all, eventually are going to be homeless,
Yeah, so a lot of good points. I don't have answers to all those things, but one of the things that we certainly saw talking to folks was the diversity of needs out there, right? I mean, every single person who's, been without a house for a long period of time has a different set of needs, right? And combine that with the complexity of getting people connected to services, right? I mean, how hard is it to get people connected to healthcare services, right? And so, I think they developed a good way to do that. But the challenge is, it's, do you have somebody who specializes in finance? Do you have somebody who specializes in social relationships amongst the people there? And you think about that. I mean, it becomes a big challenge. And how do you do that in such a way that somebody is approachable and familiar and all of that? So it does become really complicated. And I think, the basic lesson I see, it's, needs are so great. It's not going to be a simple solution, and it's not going to be a cheap one that fixes all of those things. So, and I think what we see here is some examples of ways that some of those challenges are addressed through kind of, old-fashioned simple ideas of familiar people, taking small steps, with their clients. And that seems to work, right? Excellent. Are there questions out there? Well, I appreciate it, everybody. Ty is going to be a student of mine starting next week. So great. You get to see my first lecture.
So excited.
Yeah, well, good. You might be the only one out there excited to take my research methods class. So it's good to hear.
Well, I expect to learn a lot. So.
Okay.
Right
Excellent.
on.
Are you under the gun?
Well, thank you, everybody. And if you're at all interested, send me an email, thilton@ewu.edu. I'm happy to talk about what we've done or research or whatever you want to chat with. So, and yeah, I'm right here in Spokane, and work over in Cheney as well. So anyway, thank you, everybody.
Thank you. Thank you very much.
Bye.
Bye. Thanks, guys.
Excellent.
Right on.
Excellent.
Thank
Rayanne,
you.
somebody said, corrected me, is homeless no longer a term that folks say?
I've definitely seen it moving more towards
Houseless?
I did a little bit of research. Yeah, we've been talking about it kind of as an FCS team, that there's a movement towards that shift in language. But from what I've found, that's really mostly guided from the provider lens. And I haven't found as much research, like, is that a preferred thing from participants? Like, how does that work? I don't think there's as much evidence to support.
And housing insecure, is that beyond? I always thought housing insecure, or it was different than homelessness.
I've never heard of that term myself.
Okay.
So I mean, this is the first time I've heard of it, is houselessness or house. So I guess it's a trend that's moving. My idea is, how do we keep from being homeless?
Right.
If we work on that aspect, I think we'll be in a better shape, right?
Yeah. Well, and that maybe, I just haven't seen it in the people who write about it still generally refer to homelessness, but maybe things have changed. Yeah.
Well, thank you for your time.
Yeah.
Thank you for your time, Dr. Kim, and I appreciate it. And this was really eye-opening for me.
Oh, awesome. Well, I appreciate it. And no, I thank everybody for doing this. And thanks, Rayanne. This was where Rayanne was when I started this research. She was at this agency. So,
cool.
I'm excited that it came to fruition. And, we had this medical arm that was tracking all the medical, right? Like, did they take their meds more? Did they have better control?
And has that data come out?
Nope, not yet.
No. Okay.
No, not in any sort of form. staff.
Yeah,
Mhm,
yeah. Oh, very interesting. Okay,
mhm.
good. Good,
All
good.
right, well, I'm gonna jump
Um,
off. You guys stay warm out or stay cool.
Yeah,
Stay
we
warm.
don't have to worry about staying warm here.
Yeah,
This-
yeah, stay
Hey,
cool out in Spokane. I'm over here in the Auburn, Washington area.
yeah, pretty warm out there too, isn't it?
Oh, yes, yes, we're about 94 or so, but you guys are getting like 100 around there.
We
I
were
think
about
today.
yeah, we were 100 downtown yesterday.
mhm.
So
Right.
Yeah.
We were at 85 by like 8:30 today. So
Oh, well.
see how today goes. Yeah.
Yes, stay cool.
Right.
All right, guys.
Thanks,
Have a good one.
guys.
You
well,
too.
thanks everyone.
Bye-bye.
Bye.